It is just a huge honor for me today to podcast interviewing Dr. Grant Stucki, DDS, MS. He's an oral surgeon practicing in Highlands Ranch, Colorado. He did his dental training at UCLA School of Dentistry 2009 and his surgery training at the University of Illinois in Chicago. He spends his non-extraction time doing oral surgery podcasts in the hopes of learning from other surgeons. He spends the rest of his waking hours raising his 6 children with his beautiful wife, Bryn. Is that how you say it? Bryn?
Yes.
He thinks he can convince at least one of the 6 to become an oral surgeon as well. And I brought him on the show. I listened to his one of his first shows, Everyday Oral Surgery, Surgeons Talking Shop, by oral and maxillofacial surgeon and bald beauty, Grant Stucki. And my gosh, you know, one of the embarrassing parts about being a dentist, and I call mine Dentistry Uncensored because I'm not here to talk fluff. I didn't start this show to make a friend. And we have to talk about ourselves, because when we don't regulate ourselves, then government's going to come in and do it for us. So whenever there's a market failure, good old government, which has right now 14 million employees, are going to step in. And 8.5% of emergency room visits are odontogenic in origin because there's no doctor open and they can't pull a tooth, or they can't start a root canal. And my gosh, dentists are always complaining that they're not treated like a real doctor. Well, you're not a real doctor if you can't pull a tooth. I mean, I'm sorry, you're not. Go work in the beauty salon doing hair, nails, and teeth blonding and bleaching and all that kind of stuff. And my gosh, and then the other thing that this last couple of elections have showed that, you know, over half of America lives in the rural. And when I go visit my 4 grandchildren in Beeville, Texas, it's 3G on the phone. There's no internet connection or speed. And they feel like they're a flyover state. And when you're in Beeville and you can't pull a tooth, they're not going to drive 3 hours into Houston to go pull a tooth. And then they put off. Now they're in the emergency room because Dr. Bleaching, Bonding, Shade, AA couldn't pull a damn tooth. And I'm sorry, real doctors can do emergency treatment and get you out of pain with extracting a tooth. And even if you can't do the root canal, you can do a pulpectomy and get it out of pain so that an endodontist can finish this thing. But thank you so much for starting that podcast, and thank you so much for coming on the show. How are you doing today?
I'm doing awesome. Yeah, just got done with a slugfest of extractions and implants and bone grafts and everything else that goes with it.
My gosh, 6 kids. My gosh. Is that 6 of 6, or are you going to someday live in a shoe?
No, 3 girls and 3 boys. We're all done. You know, I was the oldest of 6, and I don't know, I guess it just happened. After the first one, I was like, I think one's enough, but then somehow we're here at 6. So there you go.
Now, did you have any while you were still in school, your oral surgery residency or dental school?
Yeah, we had 2 in dental school, 2 in oral surgery, and then 2 afterward.
Oh, this has got to be a movie. And looking at the last Oscars, it would have been the #1 hit. I mean, that was the biggest list of depressing movies I'd ever seen in my life. But you know, but that makes a great point, because one of the problems of being a logical human being aware of your own existence is you start thinking, whereas animals are trapped in the present. They're just going from stimulus to stimulus. So in order for a human to be aware of its own existence, you have to disconnect from the present reality, and then you're off to Disneyland and Disney World and all these fantasies, and you start overthinking about setting up a practice or starting a family. And I graduated May 11, and 133 days later, I had my dental office open, and I am so proud. I made my 4 boys in under 60 months, and by the time I realized that this was really a bad idea, starting an office and making 4 kids, I was done. I already had my 4 kids. and I have my
Nice.
dental office, and then I leave these kids a day, and they come out and they get a different job every year for about 5 years. In about 5 years, they'll have 5 jobs, going around, sticking their foot in the water and overthinking everything. I can remember how I learned to swim. My 2 older sisters are nuns, and the oldest one, who's a cloistered Carmelite monk, she just shoved me in the swimming pool, and I literally thought I was going to drown until I regained my composure and didn't die. And that's the way to do it, man. If the meaning of life, the only meaning of life, is to survive long enough to reproduce and have offspring so that someone's still alive when you die. And if you've always thought you wanted 3 kids, well, you know when the best time to have 3 kids is? When you're so damn young and dumb, you haven't thought about it. You got all kinds of energy. For 10 years, I don't care where I put my babies to bed. When I woke up, they were all in my bed. And I'll never forget, you know, you hear them potty, poop, puke, the whole 9. I'll never forget the rock bottom of mine was when Eric, my oldest, who was born in 89, so he's now over 30. He woke me up, and he woke me up by taking his thumb and lifting up my eyelid, and he said, Cheerios. So I take him in the kitchen, I'm making a bowl of Cheerios, and he's eating one at a time, and I'm looking at the clock, and it's 4 in the morning, and I have a molar root canal at 7. And I'm just like, oh my God, this is just, but now he has 4 kids. And so, you know, just if you want to start your own practice and you want to start a family, get her pregnant tonight. That's my only advice. Just do it. You'll be so glad you did it. And congratulations on 6. That is just amazing. I was one of 7. That was just an incredible childhood. So, and you got a younger brother in oral surgery school.
Yeah, he's in his first year at Case Western. And we talk on the daily about all his hardships, and I try to be a mentor to him, and it's awesome.
That is amazing. So where does this come from to have 2 kids out of 6 become oral surgeons? There got to be a grandpa, uncle, cousin, nephew, someone else's.
Dude, yeah. So I'm a 3rd generation dentist. I have 7 uncles and 5 cousins that are all general dentists. And I was the first to specialize. And then my younger brother will follow in the footsteps. But I mean, that's all we talk about at family reunions is how did your bridge prep go? Or what happened to that tooth that you lost in the sinus when you were trying to extract it? And, you know,
so 3rd generation dentist with 7 dentists in the family tree?
No, more than that. 7 uncles, 5 cousins.
7 uncles and 5 cousins?
Yeah.
Are all dentists?
All general, and a brother-in-law. I forgot him from my other side. A lot of dentists.
Wow. And where were you born and raised?
Born in Torrance, California, raised in Los Angeles area, Orange County, and then also partially in Utah County. My dad transferred his practice up there, and so then I went to college at Brigham Young, and then back to Los Angeles for dental school.
And lived in Chicago. So my gosh, you've lived in a lot of places, and now you're in Highlands Ranch, Colorado.
Yes.
So how many states have you lived in?
And that's a good question. I also practiced in Tucson, Arizona, which I think is close to you, right? Are you still in Ahwatukee?
Yeah.
Yeah. So I was there, but I don't know.
And the president of the American Dental Association is an oral surgeon from Tucson, Arizona.
Oh, really? Oh,
Dan Clemenson.
Awesome. Yeah, very cool.
Oh, so did you like Tucson?
You know, I really did. It's a kind of a groovy place. It's different. When we got there, it seemed like we had landed on Mars. It's kind of a funky atmosphere, but the patients, everybody was nice, and it was good. Yeah.
Well, I'll tell you what, the best vacation I ever took my boys on is we got an RV and we drove over to San Diego, all the way up to the beach to Canada, crossed down to Minneapolis, down to Kansas, New Mexico, back. And then I had to throw the RV away because the last stop was elk hunting with a dentist out there, Craig Steichen. And he told me I was going to have to carry all this gear, like 5 miles. And I'm like, are you out of your mind? This RV will do it. And it's a brand new RV, and I'm following him in his 4-wheel drive. Everything's fine. But on the way home, they're just like, this weird vibration. And anyway, long story short, Monday I went back to work and I had my staff take it down the RV to get all cleaned up after a 6-week journey. And I'm in the middle of doing something. They said he needs to talk to you on the phone. I said, no, just take care of it to handle it. Well, I'll pick it up when it's, and he said, no, he has to talk to you on the phone. I said, I don't have time. He said, he wants to talk to you right now. And I got on the phone. He goes, dude, what did you do? The A-frame is broken in half, and we are not allowed to fix this. This whole thing is scrap. And I thought, and I'm in my head trying to take the $87,000 of the RV and divide it by the nights I was gone to see how much of a hotel I could have. But it was the most fun. And then the other trip was Phoenix, around the Grand Canyon, through Bryce Canyon, Utah, Idaho, Montana, up into Alberta. Holy moly. That is, I don't know what living on Mars is going to be like, but I'm sure at nighttime when it's 2.7 degrees Kelvin, that's going to be bad. But that was the most beautiful trip I'd ever taken in my life. That is just truly, if there ever was the God's country, it's that trip from Phoenix to Canada straight north. But so I want to address what I started with, and that is, you know, there's dentistry is a 200-year-old profession, and my gosh, everything that's been around forever, it grows a little bit faster than the economy, about 1.5% more when it's going up, and then it contracts a little more when it's going down because it's treated as a luxury item. It's like the cruise industry is decimated, things like that, and the only two areas of dentistry that's growing around the world in double-digit growth is clear aligners, followed by implants. I think clear aligners started, I think globally, I think there were 14 million orthodontic cases started last year in 2020, and implants. So when you're coming out of school with $400,000 student loans, you better pay attention to either clear aligners or implantology, because if you got $400,000 of student loans, I don't know if a cleaning exam and a few fillings and sealants is going to pay that back. But so many dive towards bleaching, bonding, veneers, and clear aligners because what you do sounds frightening, and it's just fear. How do you, and in 2 months, I got 2 dental schools in my backyard, Midwestern in Glendale and A.T. Still and Mesa, and they're going to dump out another huge graduating class, and these kids got to hit the ground being productive. But how do you coach them if they have a fear of blood and guts?
Gosh, that is a good question. You know, I think step one is kind of getting your feet wet with shadowing, taking a look. I'm always open to anyone coming and hanging out with me. You know, I think implants are a tricky thing. They're one of those things that it looks super simple. You drill a pilot hole and you drop it in, and you got half the dentists out there thinking that it's a no-brainer, and then the other half are terrified to get into that world. But I think we have to find some type of balance and realize that, yes, the vast majority of them are pretty simple and easy, but there can be some pretty gnarly complications that happen. And so you got to be kind of aware of those things and have some plans in place to know what to do if stuff like that happens. And I think if you've got that set up in your mind, you start relaxing a little bit and knowing, hey, you know, I can start doing this stuff.
Your first post on Dental Town was about my 2 lowest levels, L4 and 5, have severe degeneration and suffered a tear from training for a triathlon. I was wondering, did you knock off that triathlon stuff? Did you go back to eating donuts at Krispy Kreme?
Oh man, I can't even begin to tell you how much lower back pain I've had and issues and things I've done. But I stopped the triathlons and improved my health and my diet, and now I'm in a better place. But man, something about chronic pain, especially in your back, can tweak your mind and give you a whole new perspective on life.
Well, no one ever needed surgery after eating at Krispy Kreme. That's all I'm saying. No, I did. I did 3 Arizona Ironmans. That was my midlife crisis. I was gonna sign up, and a couple other dentists out here, Brad Sandvik and Louis Core and Jay. Jay was, oh my God, he's an oral surgeon too. So I did 3 in a row,
Wow.
but the only reason I stopped is because the bike part. My gosh, someone's always getting ran over by a bike out here.
Yeah.
And I remember one day, me and my trainer, oh, this is the genius part. I hired 2 personal trainers that were my age, gorgeous, the prettiest women you've ever seen in your life, to alternate. So every other day, they each did every other day, knocking on my door at 5 o'clock. And it's just so much easier to train when your personal trainer is a rock star, movie star. But one day, me and Wendy, we almost got killed twice on one bike ride. And I just said, this is insane. I said that I'm going to get killed. So
Yeah.
all with Stucki 30 years ago, you could do that. But
Got it.
now you're just asking for death. But my
Yep.
gosh. So did you that reminds me of something that I lived through in dentistry when I was in dental school. I graduated in 87. And at that time, all these ergonomic people were talking about sit down dentistry in a chair and HIV. You had to wear gloves. And in Wichita, I'll never forget Bernard Peltzer saying, you need to stand up. They're going to tear their back. And everybody I know that's sitting down is already whining about their back. And here it is weird. It's 30 years later. And just your profession, the oral surgeons, still do all stand up.
Yeah.
And from the endodontist to pediatric dentist, it's all sit down. And you are an oral surgeon, and you know all this stuff. And do you think, after having back surgery, which was better, sit down or stand up when you're nursing a spine injury?
Honestly, I think variety is what's best for your body. I think doing the same thing over and over is what's really gonna crank your back, torque your discs. And so I mix it up as much as I can. I stand half the time, sit. I'm on the right side of the patient. I go to the left side to take out left-sided teeth. All the research I've done kind of supports that says you got to change it up, and then you've got to stretch as much as you can, if possible, during the day, during procedures. But I think certainly there's more loading on your lower back when you're sitting. That's a proven fact. We know there's more pressure on your lower discs. So standing technically is a better posture, but we're talking standing upright, not standing bent over 90 degrees like a lot of surgeons are doing and just cranking the heck out of their back.
And then implants. I noticed the biggest thing in implants is there's a lot. I don't know if it's a joke or real, but a lot of people are thinking any day now with a Yomi, I can stay home in my jacuzzi and eat ice cream all day while my computer robot places all my implants. How far away are we from that?
From robots placing dental implants?
Yeah, those. You've seen it, the Yomi, right?
Yeah, I don't know. I've seen surgeons doing gallbladder surgery, from different countries, zooming into our country and doing a gallbladder surgery, on a computer and through a machine and a computer. But I don't know, man. If humans haven't gotten implants quite right, I'm still learning it. I don't know how you're gonna navigate doing it through a machine quite yet. I just don't think we're quite there.
So how are we going to get these kids to embrace trying something that's they're afraid of? I remember, and I know some of my techniques might have traumatized my kids, because I noticed the oldest one always reminds me of the time when we went skiing, and he wouldn't do it. He wouldn't do it. We got all the way to the top, and we're at Breckenridge, and he wouldn't do it, and he wouldn't do it. And finally, I just pushed him down the hill, and he screamed and yelled. But by the time at the bottom, he's all cheery and happy. Kind of reminded me when he was like 20 and we did it parachuting. It was really scary on the way up, but as soon as we landed, the first thing he said is, I wanted it again. But he's told me that story so many times, I almost went wonder if it's trauma or something. But how do you get someone? They're in a dental office. They're all by themselves. Even if they're in group, maybe the other doctor went home. It's 5 o'clock. It's a toothache. She's thinking my oral surgeon closes at 5, and it's just fear takes over. And she says, I'm going to give you antibiotics and pain meds and reschedule this with an oral surgeon. And it's just fear. How do you negotiate that?
Well, I think part of that answer is the relationship between the dentist and the surgeon, because I think a lot of dentists, they have two fears. One is really the fear of messing up and having the oral surgeon look at it and, kind of mock them or scoff, and they're just thinking, I don't want to get into it. And the other part is the fear of the patient, and having to say to the patient, hey, I got half the tooth out, but there's still a root in there. You got to go see the oral surgeon tomorrow. And so I think if we're improving our relationships and the dentist knows and has talked to their surgeon and says, hey, if it's past 5 and I try to get a tooth out and, maybe I can't get a certain root, are you okay seeing them the next day and trying to finish the job? And the surgeon says, yeah, that's fine, And I think if they have that good rapport, boom, we've eliminated one fear of messing up and someone trying to make a fool of you, that type of a thing. And so I think that, the more you can kind of get your feet wet, take a look and see what's going on, and then just try it, and be brave and do your best, and know that if it's a good referring doctor who you're sending them to, they're going to be okay, that they're understanding that you did your best and you're sending them to the surgeon to try to finish the job if you couldn't do it.
Well said. I was lucky. Don Gass is an oral surgeon out here, and he'd always see the emergency. I'd pull out the top half and drive him over to him, and he'd pull out the bottom half. Then it was after 5. I had another dentist up the street that would do it too. And I think it's so important to have colleagues and friends, and you're not, these aren't people you're competing with. You're competing against trips to Disneyland and all that kind of stuff. And it was just so nice to have that buffer. But after a year, I don't think I ever had that problem. How long has it been since you actually threw in the towel after an extraction?
My gosh, I can't remember. I mean, it's been at least 6 or 7 years. I will say there are times where it's getting difficult, and I'll take out 1 in 32, and we're backed up, and the patient's struggling, and things are going tough, and I'll throw in the flag and say, hey, let's come back and take out 16 and 17 another day, And so I've gotten to that point where I don't have a problem saying stuff like that. I don't, I feel like I want to do what's best for the patient, and if we're kind of getting in a bad scenario or they're thrashing around during a sedation and I'm not feeling comfortable with it, you got to abort mission. But I mean, it's been a long time since I couldn't get a tooth out.
Well, one of the things I've learned on Dental Town is when we put up an online course on oral surgery, which I wish you would do that. I mean, we have Jay Resnick, that's the guy I did the Ironman with. He did a couple courses and all that. But my gosh, when non-dentists give courses on oral surgery or non-endodontists, there's 12 specialties. And I know the herd only wants to learn pediatric dentistry from a pediatric dentist. Right. They don't want to learn general dentist. And but on these online oral surgery courses, I wish you'd make one, because I keep asking for the special course, and you might be the special guy that does it. And there's 8 billion people, and there's 2 million dentists, and 1 million of the dentists work just like we do in Canada, Australia, New Zealand, etc. And 1 million dentists are I call them in the bush, bush dentists. Yeah. And on dental missionary trips, I always thought the most important thing was to find out who's the guy that's doing it in this village? And you got to get connected to that guy. And then over the years, you know, he can email you and you can send him supplies. A lot of times you can go to Patterson or Benco and they'll give you a bunch of expired stuff. But, and then when we were down there, it's like I'm teaching him. And I can't tell you, one time I was down there, you know, I left all my dental gear. It's kind of like when I climbed Kilimanjaro with 3 other dentists. And my gosh, it took a week to get up and down. And it was a great feat. But when you realized all the guides were like barefoot and holes in their shoes, I left all my Kilimanjaro gear with these people because it meant the world to them. And when you meet a dentist out in the field, it just means the world to them to leave them an elevator or some, you know, criers or all this stuff he never even imagined existed. He just had some forceps or whatever. And in cosmetic dentistry, half the world, the greatest cosmetic dentist is someone who can take an impression and make a flipper to replace that front tooth. But all my cosmetic dentists that make online CE courses, they want to make it with CAD CAM and lasers and all this fancy stuff. And it's like, okay, that's only going to help half the planet. Remember, if we reduce the planet to 3 people, one has a smartphone, one just has a cell phone with no internet connection, and one has nothing. And everybody's always worried about the person with the smartphone. And I can't get a cosmetic dentist, or I can't get anybody to make me a course so that some guy, I mean, I've lectured in 50 countries. When you're in Somalia and Tanzania, you know, cosmetic dentistry is making a flipper to replace this little girl's missing tooth. And it's the same thing with exodontia. I've always wanted someone needs to make a course for the bush dentist out there, you know, like, you know, you don't have nitrous. Putting them to sleep's not an option. You're in Tanzania and it's you or go home. You know, this is the buck stops here, and nobody wants to make an online CE course for the 1/3 of humanity that doesn't have a phone, a text, or a smartphone. But I do think if I was an oral surgeon like you, I was gonna make a course, the first thing I'd just do is just the psychology of confronting fear. How can you go where you're afraid, you know? And so you talk about on your podcast of improving your clinical oral surgery skills, as well as your communication skills with your patients, assistants, and front desk staff. You seem like a really easy guy to communicate with. Why is that a big importance to you? Is it because of the history brand of surgeons and hospitals? I mean, I remember when I was doing my 6-week hospital rotation at True Medical Center East, I think every 3rd word started with F, and it wasn't fire truck, and they threw stuff, and they were just, I mean, they were some of the nastiest people I'd ever met in my life. And I used to always forgive them, because if you spend 3 hours on a car wreck, I saw this one time at St. Joe at Creighton. They spent 3 hours on this lady who was driving, and the steering wheel crushed her, and then she finally died at the end. The OR looks like a tornado hit it, and then it dies. There were no happy campers in there. It was just raw. And I always noticed that they all smoked several packs a day, and by the time they were 60, they had about 6 different wives. And I just thought my decision to be a dentist was so good. I just did not want to live in that environment. But did you, are you focusing on this because your growth in oral surgery, did you see kind of the same general attitudes, or were they less friendly and communicative than, say, a pediatric dentist?
I think so, in part. Yeah, that the oral surgeon oftentimes, I think because the residency is so difficult and we get such a beat down every day, that you become very hardened. And in the end, you know, you're kind of broken down and you become a new man, so to speak. And a lot of guys are not great at communicating, because the ways we were taught in residency was not good. We were yelled at, we were humiliated, we were, you know, treated poorly. And we took a beating, and when we get done, we kind of look at everyone else who hasn't done that, and in some ways look down on them and say, hey, you know, like, you didn't have an ounce of what I had to go through, and so you shut up and listen to me. I'm the man. And I think that whole mentality just creates a lot of trouble for oral surgeons because, when we get out, I think the tables are kind of flipped. It's actually the dentist who's almost on top, and they're the ones who feed the surgeon, and the surgeon has to learn to kind of improve their communication and work and not think of I'm better than you type of a thing, and we're on the same plane and I'm your friend. And it's tough. And a lot of surgeons really struggle with that. And so that's a main focus of my podcast.
Yeah, and the other thing that's even weirder is historically, Pierre Fauchard was a barber surgeon, that first guy to drop the barber and make dentistry a specialty of medicine. And then the orthodontists and oral surgeons come along and say, no, we're a specialist. No, you're a subspecialist of dentistry, which is a specialty of medicine. And we're all, and you see that. And the first time I ever saw it, not that way, is when I was climbing Kili. We were all the way over in Africa, and we're eating in a restaurant, and this lady says, so all 4 of you are dentists? She turns to oral surgeon, she goes, so you're a dentist too? And he said, yeah. And usually the answer is, no, I'm not a dentist. I'm an oral surgeon. And I'm like, well, did you turn in your dental degree, or was it taken away from you? So yeah, and my joke is that the reason dentists are such egomaniacs is because the stakes are so low.
Right.
And, and I just try to get everybody in dentistry to keep one eye on the patient, one eye on cost. And when everybody's fighting about their turf, like the orthodontist wants to do all the ortho and he doesn't want the general dentist to do it, and blah, 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 and the insurance companies and the dental, it's like those are all top line numerators, and all divided by the opposite, which is the denominator, which is the patient. And it's all about the patient. And it's such an easy litmus test for me, because I just always, anytime there's a question, I just think, well, if I was the patient, how would I want to be treated? What would I want done? She wants to do this to save money, and the insurance saying this. All that aside, what if that was just baby Howie sitting in that chair? How would I want to be treated? And now it's really easy because I got 6 grandkids. I just and I'm not saying my favorite is Taylor and Evelyn, but they are, because they're my first 2 girls. I had 4 boys, but I always think, what would I want them to do with Taylor, Marie, and Evelyn? And then it's crystal clear. I never have any doubt when I think what would be the best thing for Taylor, Marie, or Evelyn. And Dennis just got to get in that guard and start doing that. So are you implant agnostic, or do they all work in your hands? I mean, there's now 400. There's 400 different dental implant companies just in the country of Italy, with 75 million people, and there was 600 registered implant companies for the Cologne meeting in Germany. So how are you supposed to come out of school and line those up from best one to number 600? How would you do it?
Yeah, that is a great question, because it is getting ridiculous with how many brands, and they all have their own parts and pieces and research and telling you, ours is the best. No, ours is the best. I mean, I would start, if you're starting brand new, I would start with a mainstream implant, probably Nobel Biocare or Straumann, something that's been around for a long time. And kind of go from there, and then talk to people who are placing other ones. But yeah.
Okay, well, that was interesting. You said Nobel Biocare, and they own a premium, like I don't know, American Airlines or something, and they own a Southwest Airlines. They own the Implants Direct, and Straumann. They have a Mercedes Straumann implant, but they bought Nobel. They bought a Neodent in Brazil for their Southwest Airlines value chain. So when these companies are selling you a Straumann, and you notice that you can get the Neodent for a lot less money, how would someone not an oral surgeon, how would somebody placing implants be persuaded to buy the expensive Nobel Biocare over the Implants Direct, or the Straumann over the Neodent, when it's, I mean, look at Straumann, those are both owned and publicly traded by the same company, started by Thomas Straumann. How are you supposed to justify buying the Mercedes and not the Implants Direct, or the value one?
I mean, so I think if you've done your homework and you know that two different implants companies are the same, they're the same product, the same good research behind them. Usually, I feel like the Mercedes, you're paying more because of customer service. You know, these people, the rep's going to show up and help you with the surgeries, and if that morning you don't have the implant or the screwdriver or whatever, the torque wrench, they're going to have it to you by 1 p.m., you know, when you need it. So, I mean, I think that's something, if you've got a cheaper implant that, you know, that's working great and it's good customer service, you know, I think all the best to you, and give it a try. For me, the customer service plays a big role because I need a guy who's going to show up, you know, at 2 p.m. this afternoon with the right implant if I don't have it. And so I'll pay extra for something like that.
Nice. So, I also noticed this, that when you find an oral surgeon who just does the exodontia, who just threw up his hand and said, look, you know, there's all these young bucks like you doing all this. I've let them have it. I'm old. I'm just going to do the exodontia. They have 40% overhead. And then when they're just like a massive implant oral surgery practice, it's all the way up to 60%. So there's a lot more overhead with those implants than anybody realize. They don't realize how many online CE courses they're buying, and equipment and brands and all this stuff like that. But it's a much higher overhead than exodontia.
Absolutely. And I've talked to so many friends of mine, and if you talk to the bread and butter oral surgeon, most of them are going to say things like, if I could just stick to 4 fully bony impacted wisdom teeth with sedation, and I could do that all day, every day, that's what I would do, right? Because that's what makes the money, and it's the lowest overhead, and it's the simplest outcome. Implants are definitely higher overhead. There's more problems. There's more infection. You're doing these on a lot of the patients are old and sick, you know, and real problems can happen. And so, if you're looking at it strictly from a monetary point of view, there's no question that exodontia alone is going to beat the implant. But there's so many more rewarding things and cool things when you start dealing with implants. And I love carpentry. I grew up doing that, construction, and it's awesome. And you just feel like a man when you're drilling that pilot hole and screwing it in and torque wrenching it and building someone's mouth back up. It's awesome.
So here's a timely question on the oral surgery forum. Dr. Tuttledum asked, could it be possible that patients who receive COVID vaccine during healing and integration phase following implant placement have an increased risk of implant rejection? I swear I have seen patients with perfect sites and ideal conditions lose their implant following a COVID vaccine injection. They describe no pain or problem up to 7 weeks, then pain starts 3 days after receiving the COVID shot and the implant fails. Next person says, I'm not sure about the COVID vaccine implant failure, but recently I saw 2 patients who never had any problems, but after the COVID vaccine, almost a month after, they got large ulcers, and both of them got diagnoses with pemphigus. So I feel, you know, and then third one, personally, I am finding much higher implant failures during this COVID time. But anyway, so is that Occam's razor? Your implants failed, and the number one song is the COVID vaccine, and you put it together, or do you think there's something going on there?
That's a good question. I think you'd really have to do some research on that one to give you a good answer. I mean, my gut instinct is that it is Occam's razor, and I average, you know, 45 to 50 implants a month, and honestly, I haven't seen any of that. I haven't seen any change with success. So that's based on my own anecdotal experience, but maybe there's something too. I mean, certainly it would make sense that you get the COVID vaccine, and maybe if you have some symptoms, it's dropping your immune system down. You're more likely to get an infection. So if people were saying, oh yeah, the implants are getting infected more, or their body's not, you know, clearing things up or healing like it should, I guess that may make sense. But personally, I haven't seen much of a difference.
Another trend that I've been noticing in oral surgery is, when they started placing implant. By the way, I wish all the kids would never forget this lesson. Is that when everyone that started this revolution back in the 80s, they were all called butchers. They were putting in subperiosteals and Ramus frames, and a lot of these people pioneered everything, and they fixed a lot of dental cripples. And then the first case that failed, the state board of dental examiners would take their license away. And I saw this and what it did to the doctor who ended up just drinking himself to death in a trailer out there in Apache Junction. It's sad. And now, now that it's finally the pioneers did all the hard lifting, and now, it's all this stuff. But my God, people are so brutal on all the new people. First they laugh, and then they freaking murder them. But one of the trends I've seen lately is that to try to use those spade proximator things, atraumatic extractions, and they're trying to you push it all the way around and around and around, instead of just going in there and just immediately laying a flap, ditching out a bunch of bone, and elevating that thing out. Do you think that's going to take over, or is that a goal of yours to be atraumatic, or is that more hype and
certainly is a goal to not reduce bone and to try to get the tooth out without harming the soft tissue, or but at the same time, I'm not afraid to reflect a flap and remove some bone with thin burrs and different things like that. I think you can go to an extreme and take 2 hours to take out one root because you're trying not to take away any bone, or you can figure out what thin burrs will work and work around it and section the tooth and a little bit buccal bone, and boom, you got that tooth out in less than 10 minutes. So I think it is important to be atraumatic as possible, but you also have to be a realist and say the surgery time is also important to the patient. It's really important to do it quickly and efficiently.
Another thing, maybe I'm old school and I need to be re-educated, but when I started my own, I was a dentist in '87, but I became a journalist in '94 when I started my newsletter magazine. And so all these malpractice people, they send you every month all their claims, because a lot of industry groups start sending you all this stuff because they want the media to get it out for their own self-interest, right? Yeah. And it seems to me, number one, whenever the case is over $1 million, someone died, and it's always from the sedation. And so I've always been massively against all this learning IV sedation and a Holiday Inn and doing this stuff, because I know what happens when someone dies, and you're going to go on a trial, and one person's dead and the other one's a rich doctor, and they're going to put you up there, and they're going to bring out a board-certified anesthesiologist who's just going to play with you for a week until nobody on the jury thinks you know anything, because that's all they do. And the only place that every hospital in America, you're not allowed to do the bypass and the tummy tuck and the sedation. They broke those up years ago. And the only people that still do that together is in our lovely profession of dentistry. And then we saw Joan Rivers, where she just wanted to get a little bump off her larynx, and boom, she died of a complication. And then out here in Arizona, my gosh, every time a 4-year-old child at the pediatric dentist doesn't wake up, no one's going to ask, well, why does a 3-year-old need 8 root canals? What the hell's going on? And no one's talking that. It's like, there's a dead 3-year-old, and it would be the end, it'd just be so traumatic. So I want to weigh in with you about the heavy-hearted question. And then right here in my own backyard, my oral surgeon, Greg Edmonds, he got an anesthesiologist 10 years ago because he said it's just faster. When he goes in there, it's ready to do his thing, and he can, and then go do a check when they're, So he does it just he says, look, I can do more cases, faster, easier, higher quality, better, make more money. Everything's about it. So I'm just like, okay, so where do you sit? You're the new blood.
Well, Howard, that's a great question. I can tell you that are currently, and for the last few years, oral surgeons are definitely under attack. Anesthesiologists do not like the fact that we are pushing propofol, ketamine, and doing general anesthesia type cases in our office. And so, it's getting ratcheted up every year. There's so much legislation that's trying to be pushed to stop us from what we're doing. I will say that I feel like the oral maxillofacial surgery training is just incredible for making us safe and kind of doing what we need to do, but at a safe, in a safe realm. I completely agree that doing a Holiday Inn course or a 2 or 3 day, even a 2-week course is one of those things that can easily give you a false sense of security and get you in some trouble. And sedation is not to be taken lightly. But I mean, I personally feel that it's such a tremendous blessing and opportunity that I can give my patients. It helps so many people who otherwise could not have done the procedure. And without me having to schedule them in a hospital, and the amount of time and money and everything that it would take to get them to a hospital and take their teeth out because of their dental anxiety or whatever else is going on. The fact that I can do that in my office so quickly, save them so much money and time, is just invaluable to so many patients. I've worked with dental anesthesiologists personally. I feel it's much safer when I'm doing the anesthesia myself. I feel like I'm quicker, more efficient. I'm more aware of the airway. I feel like when I have a dental anesthesiologist, I kind of forget that stuff and I rely on them to kind of figure out if the patient's breathing and things like that. So I like to be in control. I feel very comfortable with it. And I feel like we're doing a great job as a profession to keep people safe.
Did Michael Jackson ruin Profanol? I mean, I have had more than one MD. One's a colon doctor, and he says I just cringe because when I doing the consult and I tell him that's what I'm going to use, the first thing he says about 1/3 of his patients say, I don't think that didn't work out too well for Michael Jackson. Do we have to use Michael Jackson? But do you get that pushback? I mean, when you tell people I'm using Profanol, what percent of them know that's the Michael Jackson drug?
So I think there's probably a lot who do, but I get very, very little pushback on propofol. I think, and a lot of parents ask, especially ones who are nurses or in the health field, what are you using? And I mean, I tell them propofol, Versed, ketamine. Very few people give me pushback. I think maybe right around that time when he died, people were freaked out of their mind, but no, people don't have an issue with propofol by and large.
So I think that, do you think the government's going to listen to these anesthesiologists and put a stop to that? Because my experience is that no one listens to anesthesiologists because they always put them to sleep.
I hope they don't. I mean, I hope they listen to us and realize that, hey, these guys have been doing this for so many years and have refined it so well. We know that a dentist was the inventor of anesthesia. And so for them to kind of try and take it away from us, I think is not fair and it's not right. And, I think when you look at the numbers, it shows that the amount of problems and deaths and things that happen under the care of an oral maxillofacial surgeon is, comparable and usually much less than an anesthesiologist in a hospital with all of their staff and equipment. Is it's the same or more complications that happen. So clearly we've demonstrated we're a safe group, but I tell you, there's a lot of oral surgeons out there that are afraid, and they're afraid that the anesthesiologists are going to pass legislation and take that ability away from us.
Yeah, and it's tough because the answer is, again, I started with 8 billion humans on Earth right now, and 1/3 has a smartphone, one has just a cell phone with no internet connection, and one has nothing. And again, what are they worried about? That rich person with the cell phone, where maybe 1 person out of 1 million dies in a dental office. Well, so regulate it, make it more expensive, so we make sure this 1 out of 3 who has nothing will keep getting nothing. And that's the way all of humanity works. They're so worried about one bad thing happening to the richest people, that the poorest continue to have nothing. I see it in intellectual property. I mean, you know, it's like 1/3 of all the kids on earth have never even seen a Disney movie because they're so worried about IP and copyrights and all this stuff. So Eisner can make $200 million a year in bonuses, when the reality is 1/3 of the kids will have never seen a Disney movie. And by the way, they've made 59 films. I turned 59 this year. I cannot believe 59 films are so tied up in intellectual property that 1/3 of all the kids on earth have never seen one. But then again, I hate all lawyers, but not as bad as the government, who's made up of all lawyers. I want to ask you another very controversial question in getting these forms and the lawsuits. And tell me if you believe it's true or not. So the dentist has an ego, big ego, and he left a little root tip, and he doesn't want anybody else to ever find it or see it. So he goes up there and opens up a Grand Canyon until he gets a paresthesia. Same thing with the sinus lift. He loses a little piece in the sinus, so he's got to go out and get, you know, a John Deere tractor and a Caterpillar to get it out. And most of the research of why they lose these lawsuits is they'll show you that if you just would have left it alone, it's such a small root tip that 9 times out of 10, nothing would have happened. And if something does happen, it's when it's being exfoliated like a splinter coming out of the tissue. And a sinus, when you lose a little piece in the sinus, again, that's never an issue unless they already had a sinus infection and a runny nose and blowing their nose. And the takeaway, if you were a dental malpractice attorney, was, dude, check your ego at the door. You broke off a 3mm root tip. Leave it alone. I'm not an oral surgeon, but this is how they sell this stuff in juries. What's your take on it?
I totally agree. I think with what you're saying, you know, I think if leaving 2-3 millimeter root is so much better, or it causes so much less harm for the patient than digging it out, troughing around it, hitting the infraalveolar nerve, you know, doing the Caldwell luck and opening up the side of the sinus to get it out. I think it's really, the problem is a mindset. You know, we have this mindset, almost like the Army, like no man left behind, and we are, especially oral surgeons, is like no root left behind, and it's very unsatisfying to leave part of the root in there. But it's oftentimes what's best for the patient, especially if you're looking at that Panorex and, you know, that root is under the nerve or wrapped around the nerve or whatever. And it's so important to have these conversations before the procedure, you know, and to say to the patient, hey, there's a good chance that when we get in there, we're going to have to leave part of that root. And that's usually totally fine. Small chance that it may exfoliate or migrate or get infected. And if that happens, we'll take care of it. But I think if you've cleared the air and talked about it beforehand, it's 10 times easier to leave the piece of root there than it is, you know, once you're in it and you haven't talked about it and you're like, oh my gosh, what is the patient going to think if I leave part of the root? And they'll think I'm a total, you know, lackey for leaving it in, or whatever the case may be. But you're absolutely right. You should really leave it if you're going to damage other structures.
Same question with a CBCT. I learned how to place implants with Carl Misch, 7 3-day weekends in Pittsburgh, and I got my diplomat in the International Congress of Implantology in the Fish Institute, and I never had a CBCT. In fact, my whole view, I do now, I have a Kodak Hairstream, but you know, the first greatest thing that ever happened to radiology, dental radiology, was not the CBCT. It was, I was 2 years out of school, and they did a software upgrade, and my Pano, I now had a R on the right side and an L on the left. That was the greatest oral surgery invention of all time. Every patient turned into Sir Isaac Newton and said, is that my right side? It's like, you are correct, Copernicus. So the question is, she comes out of school, she goes to a small town, she's working with her mom, and it's just a Pano, and she's convinced that no one ever pulled a tooth without a CBCT, and, you know, how is this happening? And she says it's below the standard of care. So my question to you is it the legal lawyer standard of care, and is there any evidence that someone ever pulled a tooth without a CBCT?
Yeah, I mean, you're talking to the wrong guy, because I do 95+% of what I do is based on the Panorex. You know, yes, there are certainly situations where a CBCT is helpful, but if you don't know how to read a Panorex and you're not comfortable and you can't figure out all the structures and feel confident with a Panorex, a CBCT is not going to give you confidence. That's just going to freak you out even more. And so I think CBCTs are very nice for showing patients things and to be able to look in 3D and look at this and that. But I can tell you most oral surgeons work off the Panorex. And even if we have a CBCT, when we're doing the surgery, we flip it over the Panorex to watch it because it's so helpful and there's so much great detail and things like that. So no, I don't think you should be afraid to take out a tooth or do the majority of implants on just a Panorex and a PA. I mean, that gives you so much of what you need to know.
Dry sockets, is it still a thing? I mean, they used to say it's women on birth control pills and smokers. Are those still the three main areas? And is it still how often is this a complication and how do you treat it?
So dry sockets are definitely, I think, becoming less and less common. For me, certainly smoking's up there. But really, I think most of it is the operator. I think it's a lot of it. The vast majority of dry socket is the burrs you're using, the irrigation you have, and your technique, how quick you are in getting the tooth out. And then now with platelet therapy, and so many of us are, pulling the patient's blood, spinning it, taking the platelets off, and dropping the fibrin clot in the extraction site. I mean, there's so many great tools and technologies and things we have to avoid dry socket, and it's just becoming much less common.
And you said smoking, but you didn't say smoking what. And you're in Colorado, and I assume you moved there because it was had legal weed at the time, and other states didn't. A lot of people don't know if this is an oral health problem or not. Do you think smoking marijuana as opposed to the cigarettes and cigars, does that make any more or less complications?
No, I think smoking cigars and cigarettes, nicotine is much worse. Constricts blood vessels. It's just shown to cause a lot more problems. I tell my patients, and I can tell you this, that in Colorado, it is insane how many teenagers are smoking marijuana and using it. Like, it seems like 90% of them, every single one almost, they're all like, oh, yep, I'm using it every single day. And so we have that discussion of it. With marijuana, it's more of the sucking motion, and that type of a thing. But the actual substance, I don't think is harmful. I think it presents a lot of challenge for the oral maxillofacial surgeon sedating people because you have to push a lot more drug to put these people down and get them comfortable. It's pretty remarkable how someone who's used weed even for a month or two are just very resistant to anesthesia medications. So,
Well, the one thing I like to think about differently is there if I needed penicillin, I'm not going to eat a tree. If they talk about the miracles of THC, well, you wouldn't smoke 38,000 chemicals in a plant. You just take the THC. And I always wondered
right.
if when they do research, if they do it differently for people who just have the THC versus people who are, smoking it. I mean, they found mold, penicillin in bread. I don't think that if you needed penicillin, you should just start eating mold with a spoon until,
Right.
you ate enough penicillin. So, I don't know. What do you think?
Yeah, I mean, I think you're exactly right that we need more studies on that stuff. My experience is that THC isn't causing any issues with anything we do, basically, other than having to give people more medications during sedation. I don't think it's decreasing healing, causing really any troubles, and pretty much everyone here in Colorado is using it. So,
yeah, and like there's a thread on dentistry and oral surgeon. This patient came in and I think they're high, and so that scares them. And I'm wondering, does that concern you on the? I mean, are you asking people, are you high now? Is that a big deal or not really?
I mean, I think it's more of a concern with consenting, and things like that. And so, if you smell the grass and you're pretty sure they're using the devil's lettuce, then you should maybe do a qualifying question to them and say, hey, are you high before you sign this? Because if so, you really shouldn't be signing your consent. But I mean, I don't have a problem doing treatment on someone, and I think a lot of patients do that. Where weed is legal, they come to the office kind of high because they're so anxious and they're trying to do things to decrease anxiety. It's like the guy who drinks alcohol and comes to the office kind of drunk because he's trying to relax himself so he can get through the procedure. It's a similar thing, and I think you shouldn't be afraid from the standpoint of doing the surgery. I don't think there's really too many issues that happen with someone who's high or stoned. Most of them are relaxed and calm, and it actually makes things easier. But of course, you got to be careful when they're consenting, that they're mentally with it and their faculties are all there before they're signing papers.
So I've lived through, it's always life is the cycle of life. It's kind of like that. Remember that game Ping, where you just bounce the ball from side to side? Like, okay, when I got out of school, there was a dental supply company in every city, if not 2 or 3. And then they started consolidating them all for Wall Street, and they got to the top. And then as soon as it got all consolidated, it bounces to their side, and now it's all deconsolidating, and you see dental supply companies opening up all over the place. I saw it with beer when I was in school. Every city had its own brewery and type of beer, and then it all got consolidated into Budweiser and Michelob and Coors. And then as soon as it was maximum consolidated, it starts the deconsolidation come down. And that's how humans work. They take it too far to the left, and then they take it too far to the right, and to the left and the right, and that's just how it's done. And I definitely lived through that with pain pills. When I was in dental school, all the media was these bastard doctors. Grandma's dying of cancer. She's in pain. I mean, what is she going to, start taking Percocet and be a stripper, or, get her out of pain? And it was like, be lenient on pain pills. So everybody got lenient, and then you got addiction, and then now it's to the point where all the way back to the side, guy, you could walk into a doctor's office missing your left arm, and they wouldn't give you Tylenol number 3 with codeine. So where are we at on the cycle right now? You're doing the heavy lifting stuff. You're taking out 4 impacted wisdom teeth. Do you still use narcotics, or is that just dead for right now?
I definitely still use them. I think they're extremely helpful. I know there's a lot of research going on, and there's definitely a lot of anecdotal stories of teenagers getting hooked on pain pills and horrible things happening. I think that's pretty rare, and it's the rare exception. And so I think to kind of punish the masses for a couple people like that isn't appropriate. I think pain pills are very helpful, especially for full bony wisdom teeth. I think we need to be able to communicate well and kind of assess how responsible our patient is and their parents, and be able to say, hey, you may not need this narcotic, but it's here for you if you need it, and let us know. With that said, I think it still is good to use things like Exparel and long-lasting Marcaines and things to try to decrease the amount of narcotic people need. But I mean, I use it on a daily basis, and it's critical for my patients to get past that healing pain.
Socket preservation. You pull a tooth, and maybe they're going to come back and do an implant. And a lot of people out there are saying that, you should buy a carpil of bone grafting, which is actually more per gram than cocaine, crack, and heroin combined. And, God, I don't want to have to sell my body to buy bone grafting material or dance after work. But the question is it really effective? I mean, if I bought this carpil of sand for $8 million and poured it in the hole. Will everyone be glad I did this?
Oh, now and now you're touching on some sensitive topics. I think yes, the literature shows that grafting generally maintains better bone levels. I think once you've been doing this for many years, you can have a pretty good sense, especially the guy who's got, just a ton of bone all around, and you can get that tooth out without much trauma to the bone. I think you're pretty confident that guy's going to maintain a good bone level, probably without grafting. So I don't necessarily think it's something you have to give to every single extraction, but it does help for a lot of people. I think combining it with their platelets also stimulates a lot of good growth of bone and can be helpful. But there certainly are people who take it to the extreme and act like it's the end all be all, and tell the patient you're totally screwed if you don't do a bone graft, and it's a lot of pressure right then to accept the $1,000 of the bone graft, the membrane, the regenerative platelets, and whatever else people are putting in there. And so I think we need to be more sensitive about the budget cost, and being realistic with our patients of how much do you need this and all that type of a thing. So that's an interesting question you bring, and I think there's a whole lot of opinions out there on that topic.
And I tell you, you got to keep one eye on the patient and one eye on cost, or people will not have the freedom to afford to save their teeth. And when everybody's talking about, the government should provide it for free. The largest employer in the United States is the government, with 24 million employees. 15 out of every 100 people already work for the damn government. And every time I see that Walmart is the largest employer, Walmart has 1.8 million people, and 95% of Americans can get there in under an hour and buy stuff faster, cheaper, lower quality. I can't say the same about the 24 million people who work for the government, making everything faster, easier, higher quality. What they do is they regulate something until it dies. But I want to ask, and back to oral surgery, I have a deep... my highest risk behavior in oral surgery is, I wish you could help me wrap my mind around it. I've always practiced in group. I've always loved to have associates, and it's just more fun. And when I see someone swollen, so many people say, first we need to treat the infection. I want to put them on antibiotics and pain pills and a couple days. And I always think, you know what the best way to treat this infection is? Get that damn tooth out of there and get some drainage out of there. And I'm not going to treat this with some pharmaceuticals. I'm gonna do this. I'm gonna extract the damn tooth and try to get some drainage out of there. And oh my God, I've had so many of my friends say, "Oh no, you're gonna kill them," and I'm like, "There's a big rotten abscess in there. How? I mean, well, they're swelling. Well, I all the more reason to take that damn tooth out of there." So how do you balance, well, let's just send them to Walgreens. That's where the real doctors are for 3 days, and then they can come back, versus get that out of them right now. Something nasty's going on, and I want to remove as much of that nasty right now, not send them to CVS.
Yeah, and you bring up a good point. And not only are there dentists, a lot of dentists who have that mentality, but patients too. Patients come to me and his face is swollen, a huge pocket of pus, and I say, "Hey, we need to take this tooth out right now and drain this thing." And they look at me, a lot of them, and say, "Wait, shouldn't I do antibiotics for a week and then come back and get the tooth out?" People don't understand, once you have a big ball of pus, you could throw as much antibiotics as you want at that thing. You could hook them up to an IV and give them vancomycin and everything, but the cause of that infection is the tooth, and now you got a big ball of pus there. Those antibiotics are going to have a heck of a time getting in and around that tooth when you got so much pus. And so I am the same mindset of you, of let's get the source out as soon as we can. I don't think there's much place for saying, "Oh, your face is swollen. Let's, do antibiotics for a week or two. I think that gives people a false sense of security. It only makes things more dangerous because now infection can spread from the jaw to under your throat and become a very dangerous thing as far as swallowing and breathing. So yeah, I think certainly it should be, let's address and get that tooth out as soon as we can. I think probably, I'm guessing a lot of general dentists have gotten into that mentality because they don't have the tool of sedation, right? And I think we know that if you're taking out an infected tooth, it's going to be painful, and there's a good chance you can't get them completely numb. And so it's easier to say, well, let's just chew antibiotics and cross our fingers that that will go down. Whereas the oral surgeon, we have that tool in our bag. And so it's like, that's a non-issue for us. If I can't get you numb, I'm going to put an IV and put you to sleep, and we're going to take that tooth out. And so, that helps us. But I think spreading the word and saying, hey, it's good to get the tooth out. If you can't do it in your office, certainly it's worth a try. Then send them over to me and I'll sedate them and get the tooth out. But it's got to come out ASAP.
I cannot believe we went over an hour. That was the fastest damn hour of my life. But I want to ask you, Steve Thorne is a good friend of mine, founder of PDS. You work for PDS. I'm in Arizona, which is the highest number of dentists work for DSO. It's 18 out of 100. In anything, there's advantages and disadvantages. In fact, one of the best heuristics you ever have is when someone's telling you something passionately, like why you should put in a swimming pool. Then you just, okay, I heard that. Addition is followed by subtraction. It's the inverse operation. Now, sell me with the same passion why you should never put in a swimming pool. And I don't care if it's economics or anesthesia or whatever. If they only know addition and they don't know subtraction, they don't know the math of what they're talking about. Same with multiplications followed by division. Square roots are followed by the square. How is it? This is a new and upcoming business model. Steve Thorne's a great guy. I mean, he's just a great guy. You work for Pacific Dental Services. What are the trade-offs, pros and cons? You like it? Would you recommend it to your little brother who's an oral surgeon? What's life like with Steve Thorne and Associates?
So the short answer is it's really good. I've worked in multiple settings. I certainly haven't done this my whole career. I've worked in a small group. I've owned my own practice and, done a couple different corporations, and now mostly Pacific Dental full time. But it's a very smooth operation compared to others I've experienced. It's the best as far as setting things up and working with a specialist. The great benefits, of course, are one, that we're under the same roof, and the communication is so much better when I'm there in the office with my dentist, oftentimes the orthodontist as well, and we can talk about cases right then. We can hit the pause button and we're all present. That is the biggest beauty of it, I feel like, compared to, okay, wait, this referral doesn't make any sense to me. I got a call across town, and of course, Tuesday, Dr. Jones is not in the office, and we can't reach him, and it's just a nightmare to try to communicate. And so it really does enhance communication between specialists and the generalist. So I love that part of it. It's wonderful for the patient, I think, because everything is centralized, it's close to home, and the cost of everything is so apparent to them, and the front desk can say, hey, here's what a sedation costs, here's what a root canal costs, and it's not, we're sending you to Dr. Stuckey across town, and who knows if he takes your insurance or not. That's up to you to figure that out. And people underestimate how hard that is for patients to deal with all of that, and it can be very frustrating for them. And so to centralize it and make that simpler for the patient is huge. And so there's a lot of benefits. Certainly it's not for everyone. I think there's a lot of cons and difficult things about, going to multiple offices and taking my equipment and, having my team go with me and traveling. And, it can be hard on the mind and the body at times, but overall it's been great for me.
But do you just work in one location, or going around to many different PDS offices in the Denver metro?
14 offices.
You go to 14 different offices?
Yes.
And so what is that? One office.
Every other week. Yeah.
So you hit 14 offices every other week to do their oral surgery?
Yeah, pretty much.
And so what would be the pro or con of building out an RV, and doing that, going to the different location?
Yeah. Yeah. And a lot of guys do that. I think the pro of that is, so and you're saying like building out your IV and just going to your own dentist's offices, that type of thing.
Well, I mean, instead of packing up and moving all this stuff and then move it from your car into the office or whatever, what if you just, you and your oral surgery team just had a big old RV? Who was that guy in the NFL that wouldn't fly that had his big RV? Remember that? John Madden. Yeah.
Oh,
so
yeah.
Everybody wanted to hear this guy. I mean, he was a coach. He knew what the hell he was talking about, but he wouldn't fly. So the NFL, after every game, had to pack him up in an RV and in the 49ers and drive him all the way to the Dolphins in Miami. And he didn't care. He just sat there and ate healthy foods and liquids. And but it just do you think it'd be easier logistics, or do you just buy everything you need and leave it in 14 different locations? Like, do you have like 14 everything you need in each location, so you don't have to carry this stuff all around all the time, or how's it work?
So yeah, basically all that I carry around is surgical trays, which that would be pretty easy and not too costly to have those just sitting in every office. But I have like 10 surgery setups, and that fits in a fairly small bag. And then I have 3 anesthesia monitors, at least 3 or 4 hand pieces, surgical hand pieces that my assistants bring in and out. But that's pretty much it: monitor, hand piece, and the surgical tray. And then everything else is provided by the office. Implants, all the disposable sutures, gauze, blah, 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 all that stuff. So it's really not too bad to pack and unpack your surgical, really the hard stuff that you need. But certainly there are guys who do that. I know of guys who have an anesthesia monitor or a couple in every single office, and and their drills, and so they don't want to transport stuff, and that certainly can be done. But I feel more comfortable bringing it into the office and doing it there, as opposed to having the patient come out to my RV in the parking lot. It seems just a little hokey. I don't know if that's what you were envisioning, but
yeah, that's what I was wondering. That's my retirement status. I just want to get a big old RV. I love those RV trips, and I've learned my lesson. I'm not going to take them for oral driving anymore. Right. But man, I was so excited to see an oral and maxillofacial surgeon starting a podcast. I love this format. I mean, when I became a dentist in 87, I became a dentist journalist in 94, starting the Bryn report. And it was a 34-page black and white. And then 2 years later, the big thing was we added color. We added one blue color, so it could have black and some blue trim on it. And that was the greatest thing. And then in 1999, I was on ESPN. And I was on the message boards, and I thought, man, I'd love to be talking about dentistry like this. So I copied and stole the whole ESPN message boards and started Dental Town in 99. And and now I've been doing podcasts for 5 years, and the format's great because you can have 2 guys interacting real time, and they need to hear from all of the 12 specialists. They don't need to listen to general dentists talking about oral surgery or general dentists talking about endo. The 12 specialists need to talk because they walk the walk, and they don't. Last thing they need is a damn critic that hasn't done anything. You know what I mean? Right. Look, if you're not an oral surgeon or a pediatric dentist, shut the hell up. There's enough people feigning expertise in the government. Last thing we need is our own homies feigning expertise. So, best of luck. Anything I can do to help you get that out. Maybe create an online CE course or write an article or
Yeah, for
something
sure.
in Dental Town. And of course, I'm extra biased because you obviously are the most beautiful bald head in all of dentistry. I bow
Yes.
down and humbly take. I did not win. And we need more bald beauties. But you'll notice, I just want to tell you kids out there that, when you're watching Shark Tank, who's the smartest guy on there? Obviously the bald guy, Mr. Wonderful.
Totally.
You'll always notice the older you get, the smartest man in the room is always the bald one. Just never ever forget that. So
100% agree.
thank you, Grant Stucky. That is no, it's Stucky, right?
Stucky, yes.
Stucky. So Grant, Stu is the key to Oral Surgery Podcast, and man, it's an awesome show. And good luck. I hope with those 6 kids, I mean, gosh, if you have 7, I mean, if you got all those people in your family tree that's a dentist, are you kind of hoping one of them is?
I kind of hope so. I just think it's a special when a father and a son, like me and my dad, can talk about dentistry. It's a cool thing to add to your relationship to be able to do that. I mean, I'm not going to disown them. If they become an artist or whatever, I'm going to support them, and that's great. But it would be cool if one of them did it.
Yeah, that is cool. Kids are so cool. But on that note, thank you so much, and good luck with all those 6 children, and good luck with your podcast at sharing high quality oral surgery information for lower costs. That's a beautiful thing.
Thank you, Dr. Fran. You're the man. I really appreciate you having me on.
All right, man. Anytime. Have a great day.
You too. Talk to you later.